again, everybody. This is Rusty, aka William Robinson, aka Dr. Robinson, and I am the Blues Doctor. This is my podcast, The Blues Doctor Recommends, and we're glad you're here. I know a lot of people will be observing Holy Week this week, and we are too. My cameraman, producer, wife, and I were in Memphis, Tennessee last week for Palm Sunday. This week we're going to be in New Orleans for Easter weekend, so we're recording a little early this week also. I only have one event on the calendar this week, but it's a good one. Rebecca Lee Crumpler was America's first female black physician. Ms. Crumpler was born April 18th, 1831. She developed an early interest in caring for the sick when she was raised by her aunt, who was something of a lay nurse. Ms. Crumpler became a nurse herself until 1855, when she was admitted to the New England Female Medical College, which went on to become Boston University School of Medicine. She graduated in 1860 and continued her practice in Philadelphia and Boston after that. After the Civil War was over, she moved to Richmond, Virginia, and began treating the ex-slaves there. She thought it was important for her to do that. She specialized in diseases of women and children, and obviously was very much a pioneer. I've mentored a fair number of young physicians, both male and female, black and white, Asian, others. But I wonder who would have mentored Rebecca Crumpler at that time. Clearly, she endured a lot to get to where she got, and I think we should all be proud of her. If you have any other suggestions about people who you think are pioneers in America and you would like for me to cover, please make suggestions or comments, and I'll do my best to do so. So thank you, Rebecca Lee Crumpler, for being a pioneer in American medicine. I decided to talk about ovarian cancer this week as our health topic for the week. We talked about that a little bit last week when we discussed one of the new medicines that's been tested for ovarian cancer. But I realized that maybe we should have gone back and done a little background on ovarian cancer as a whole itself first. So that's what we're doing today. So, ovarian cancer is a relatively uncommon disease. There aren't more than 15,000 cases of ovarian cancer in the United States each year, which is very many fewer than breast cancer. There's 200,000 cases of breast cancer in the United States. However, ovarian cancer is much more deadly than breast cancer. There's something like 10,000 deaths out of those 15,000 cases every year in the United States. So ovarian cancer is a tough one. We have been treating ovarian cancer for many years, and we still don't really have a good handle on it. The risks associated with ovarian cancer are difficult also. The risks that we know of include childbearing. We know that if you have few or no children, you're more likely to get ovarian cancer. A preventive is oral contraceptives. If you take birth control pills for at least a year, we know that the risk for ovarian cancer goes down. And then finally, we know there's a familial risk. We discussed here a few weeks ago the BRCA gene, or breast cancer associated gene, that raises an individual's risk for breast cancer. So, what can you do about risks? Unfortunately, these risks are not really modifiable. You can't pick your parents. Realistically, nobody is going to make a decision about childbearing or about taking contraceptives based on their future risk. So, unlike some other cancers, there's really not much you can do about your risk for ovarian cancer. The symptoms of ovarian cancer are relatively vague, unfortunately. They can include bloating, or constipation, or nausea, or diarrhea, or other vague abdominal symptoms. In fact, I had a talk I used to do to state medical societies or county medical societies and speak to a group of primary care physicians and ask them, so this week, how many of you have seen a patient with one of these symptoms? And I would show a list. It would include abdominal bloating, constipation, nausea, low appetite, discomfort. Every hand would go up. Then I would ask, well, so how many of you have seen a woman who ended up having ovarian cancer in the last year? No hands go up. So what that tells you is the symptoms of ovarian cancer are so vague that they're not even really helpful. Most people who have those symptoms do not have ovarian cancer. So how do you make the diagnosis? It's really not easy. Patients who have those symptoms may undergo imaging studies like a CT scan or an ultrasound or others. They may have a physical exam, which might show a pelvic mass or an abdominal mass. They might have tumor markers drawn, in other words, blood tests for specific markers that may indicate cancer, specifically ovarian cancer. But even putting all of that together, you still don't know whether a woman has ovarian cancer or not until you can surgically remove a piece of the cancer, put it under the microscope, and look at it to determine the real diagnosis. So, ovarian cancer is hard, both symptomatically and to diagnose. The treatment for ovarian cancer is almost always a combination of surgery and chemotherapy, and that's been the case for a number of years. Our chemotherapy drugs have improved dramatically over the years, but surgery is still the primary piece for the most part. The idea behind surgery for ovarian cancer is called debulking, or removal of as much of the cancer as you possibly can surgically so that you leave as little as possible behind. We know in that case that the patients will respond better to chemotherapy. So, our goal for ovarian cancer surgery is to leave behind disease no bigger than a centimeter in any diameter when you're finished with the operation. Even better if you can leave no visible disease behind whatsoever. Then, after that, after you've recovered from surgery, we usually recommend chemotherapy to those patients. The chemotherapy, typically for ovarian cancer, lasts around 6 months and includes a combination of drugs. And most people, most patients, will get a response from that. In other words, at the end of chemotherapy, they will be presumably disease free. Their symptoms will have gone away, their physical exam will be normal again, their imaging studies will be normal, and their tumor markers may have gone back to very low levels. So that's a good thing. Something like 75% of women who truly are diagnosed with ovarian cancer will get a response from surgery and chemotherapy. Unfortunately, those responses aren't lasting. Of the women who get a response to surgery and chemotherapy, something like 75% of them will have the disease recur or come back, typically between 1 and 2 years after the treatment is ended. We usually treat those women again with chemotherapy of some kind, sometimes even the same chemotherapy they had before, sometimes with other agents. Unfortunately, we know that women who have recurrent ovarian cancer after chemotherapy will almost certainly succumb to their disease. In other words, they will die of their disease typically 3 to 5 years after recurrence. However, most of those patients will get a response again to some form of chemotherapy. So it's clearly worthwhile for those patients to consider secondary chemotherapy, as we call it. In other words, chemotherapy a second time around. The new targeted agents for ovarian cancer, as we discussed a little bit last week, certainly have promise. Several of the trials that we've done recently have showed survival advantages that you can measure in months, which is a good thing. It's not exactly clear yet whether those targeted agents have an impact on overall survival for ovarian cancer, but they're certainly very promising. It's interesting, in the last 5 years or so, there have been more new agents approved for ovarian cancer than in the previous 25 years that I was in practice. So it's a very promising area of research. I would be encouraged, am encouraged, that we are on the right track for ovarian cancer, but it's still a very difficult disease. And that's all I really wanted to say on ovarian cancer today because I didn't want to take too long or get into too much detail, but we may revisit that in the future at some point or revisit specific parts of it based on either your comments or suggestions or maybe even current events. I was talking to somebody this week about music in general, and they pointed out to me, this person pointed out to me, that I hadn't really discussed blues music on the podcast very much, despite the fact that my name supposedly is the Blues Doctor. So I thought I'd try to remedy that a little bit this week. Blues music originated in the Mississippi Delta among the farmhands, almost all black, usually sharecroppers, who created work songs, basically songs to last them through the day when they were working very hard. Some of those songs may even have been derived from songs that came over with them from Africa in the slave era. Those songs evolved over time, particularly as the sharecroppers left the Delta. Some of them went to New Orleans, some of them went to Memphis, some went to Chicago, and changed into the blues that we know today. Blues music has never really been a top seller among music. There have been blues charts, R&B charts for some time, and there have been hits on those charts, but they never really crossed over to become mainstream bestsellers. However, I still think it's a very important part of music today. Blues-based rock and roll was really the basis of popular music for the second half of the 20th century. The Rolling Stones were nothing more than a blues based rock band. We actually used to have blues concerts on my front porch in New Orleans. I have a video of one that I'd like to share with you now. This was on our front porch during Mardi Gras. We invited a number of local musicians over to join us in a impromptu blues concert.
Before you go, I want you to rock me, mama. Rock me all night long. Oh, I want you to rock me, mama. Just like my back is all over on. Come on, Joe.
I hope you enjoyed that. We really enjoyed having so many great musicians from the New Orleans area who agreed to share their talents with us that day. It was almost a who's who of New Orleans blues musician for our Mardi Gras front porch concerts. Maybe someday we'll do something like that again. For our high strangeness this week, I thought we could talk about the Shroud of Turin for a couple of reasons. Partly because it's Easter week, partly because it's been in the news lately. You may have seen in the news that there's been a new radiographic technique reported that seems to date the shroud more precisely than previous techniques have. Plus, I thought I'd talk about the history of the shroud a little bit before we got to that technique. So, the Shroud of Turin is a piece of linen that has an image on it that many people have presumed to be an image of Christ after he was crucified and laid in the tomb. The shroud, as we know it, dates to at least 1354. That's the first time it was recorded. And this was in a church in France. It was owned by one of the royal families. The shroud was traded between some of the royal families for a while after that until finally in 1578 it was moved to Turin, Italy, the church there, and actually became the property of the Catholic Church or of the Pope at that time. Since then, for the years after that, the shroud had kind of languished. I mean, pilgrims knew it was there, but it really didn't have a national presence as it does today. Well, that all changed in 1898 when a photographer named Secondo Pia, Pia, photographed the shroud for the first time. And actually, the interesting part of that was not as much the photograph, but the negative that Mr. Pia obtained from this. When you look at the photographic negative, it actually looks like a positive image of a man on a cross. It's much more realistic than the actual shroud itself is. It appears to be a man who has wounds in his hands or arms, feet, and on his side, depicting the wounds of Christ. He appeared to have injuries to his back, his chest, consistent with being scourged. It seemed to have images of a crown of some sort being pressed onto his head that caused bleeding. So it was a remarkable image that many people have suspected may represent Jesus Christ after he was crucified. After that, the shroud got lots of international attention, And there were a number of efforts to try to prove that the shroud came from the Holy Land, dated to the time of the crucifixion, and potentially did contain the body of Jesus. There were any number of attempts by 20th century researchers to prove that with all kinds of techniques. Perhaps the most important one, though, was in 1988 when a group of researchers got together, went to the Pope, and requested that they be allowed to test a part of the shroud based on radiocarbon dating. Radiocarbon dating was, at the time, a relatively new technique that allowed scientists to date samples for which the origins were unknown. And it appears to be extremely accurate down to a level of within like 70 years or so, even thousands of years in the past. The church agreed to this and allowed the group to take samples. The samples were about 1 by 1 centimeter. They were taken from areas other than the actual image, so it did not destroy the image. A piece of the shroud, that 1 by 1 centimeter piece, was given to each of three different laboratories. One was at the Swiss Institute of Technology, one was at Oxford University in Britain, and one was at the University of Arizona in the United States, which is one of the leaders in DNA testing in that era. The universities were also given, in blinded fashion, pieces of linen from that era so that they could test them too. In other words, pieces of linen that were not from the shroud to act as a control. At any rate, all three of those labs did their testing separately. They did not communicate with each other until everybody's tests were done. They then all got back together and compared their results. They presented those results at a major news conference in 1988. All three of the results showed uniformly that the shroud dated from between 1290 AD and 1360 AD. In other words, it was 1200 years younger than it needed to be from Jesus' crucifixion. It was medieval, in other words. Now, that would suggest, obviously, that the shroud is some kind of a forgery or a fake. However, there are a number of characteristics of the shroud that we still can't explain or understand, and I've got several of them listed here. Number one, the shroud is made of linen. The weave in the linen is known as herringbone, which was used in premillennial times, in other words, at the time of Jesus Christ. It was raw, it's unprepared. Linen repels water, so it's therefore difficult to paint. And in fact, no one has ever been able to determine that paint was used to produce the colors, the images on the shroud. It seems as though the actual fibers of the shroud themselves have been changed in color somehow to create that image. It does not seem to have been somehow painted on the shroud. Second, the lines on the shroud that make up the image that's seen are about 1/100th of an inch thick. In other words, they're way too small to have been created, especially in the Middle Ages, from an artist's brush. So, how did those lines get there? We don't know how. Third, there's no artistic style to it. There are no brush marks. Like I mentioned before, there was no pigments or paint. It really looks like a photographic image rather than an artistic one. The image on the shroud is actually a negative, as I mentioned before. The concept of negative images was only imagined before the invention of photography in the mid 19th century. So, how did the image get on the shroud in that nature? Again, we don't know. Another point suggesting that this couldn't be a photograph is that there were no silver or silver pigmented compounds on the image itself or on the shroud. In those days, in other words, the origins of photography, they were all silver colloidal based. And there's been no evidence that this has been found on the shroud so far. And this one is particularly fascinating to me. The image on the shroud is three-dimensional. The image seems to be proportional to the nearness of the object underneath it to the cloth itself. The nose was immediately adjacent to the cloth, and the image there is much darker than are the eyes, which presumably were further away from the cloth. That concept, that is a three-dimensional image, was really not known before photography came to be in the 19th century. The new information about the shroud came from late last year, late 2024, and it was known as wide angle X ray scattering, or WAX. There was a report that came out last year about a man who used this new technique, WAX, to determine that the shroud was much older than radiocarbon dating indicated. In fact, it suggested that the shroud could, in fact, date back to the time of Christ. Now, I'm not going to try to explain the technique of wide angle X ray scattering. It does have some critics, but it certainly throws another monkey wrench, in a sense, into the discussion of the cloth. So that's all I had this week. We do have some new friends of the podcast that I'd like to introduce. Chad and Erica Black. They are the creators of the Oddcast podcast, and they discuss a variety of interesting topics on there. I would encourage you to look them up. Also, Selena Garrett. Selena is also known as the Southern Belle Bigfoot. Her podcast discusses Bigfoot in a lot of different ways, and she's a very pleasant lady also. Finally, Kalila Smith. Kalila is a good friend and now is a friend of the podcast. She is the GM, founder, owner of Haunted History Tours in New Orleans. If you're in New Orleans and find yourself interested in the architecture of the old part of town, particularly the French Quarter, and some of the stories that have gone with that, there are many haunted places, we believe, or haunted stories in the French Quarter. The Haunted History Tours are the tour to use. I've been on it. It's terrific. There are a number of other tours, but most of them are probably not worth the time or effort to take. So, Kalila, thank you so much. We're glad to have all of you all, Selena, Chad, Erica, Kalila, as new friends of the podcast. So, the Blues Doctor's prescription for the week. Think about the Shroud of Turin and about what it means to you this week, in the week of Easter. Also, maybe consider Dr. Rebecca Crumpler. Think about what she had to endure as America's first black female physician. Or go find a blues club near you if you want to listen to some good music. I love it, and I encourage anybody else to find one too. Most major cities have good blues clubs now. Also, please like and subscribe, ring the bell, share, make comments or suggestions. I love reading them. And finally, as I say each week, please listen to next week's podcast. Okay? See you later.